Welcome back. Enterotomy is the incision on an intestinal segment, and it is usually indicated for the removal of foreign bodies. Let's begin our discussion. The patient is positioned and prepped for an abdominal surgery. A ventral midline ciliotomy is done, and the abdomen is packed with saline moistened lap sponges. Same thing as how we do the gastrotomy and gastropexy. This is classic beginning of an abdominal surgery. Assess the whole abdomen for signs of peritonitis and hemorrhage. Suction out if you encounter free fluid. And then exteriorize the intestinal bowels to locate the foreign body. Now, most of the time, intestinal bowels ORAD to the foreign body is dilated than the others, as you can see in this image. This is the foreign body. This is the intestine that is going to the head. As you can see, it is much more dilated than the distal segment to the foreign body, which is going to the tail. We call this area ab-orad and this area as orad. Okay, that's how we use our directional terms when we talked about the intestine. Now, once you have located the foreign body, assess the viability of the bowel, where the foreign body is lodged into, and the adjacent intestinal tissues. If the bowel is viable, an enterotomy is the chosen surgical correction procedure. If it is not, then it is a resection and anastomosis, which we will be discussing in the next video. Make sure to pack the intestinal segments with the lap sponges. This will prevent the ingesta right here. It has the sponges, the white ones. These lap sponges will prevent the intestinal contents from contaminating the peritoneal cavity. The intestinal tract is occluded 5 centimeters, orad and ab-orad, to the ends of your planned incision. You may use your assistant surgeon's fingers to do this, or use a pair of Doyen intestinal forceps. A longitudinal incision is made on the anti-mesenteric border of the healthy tissue ab-orad to the foreign body. This is seen in this image. Right? This is the foreign body. You see some dilated part in here, and this is where you will put your incision. Now, some would actually prefer to cut along the area where the foreign body is, but you have to assess if the tissue could handle that. For example, on this side, there are signs of necrosis already, so we do not want our incision in this area, even if it will make the removal of the foreign body much easier. We have to make sure that the wound that you make will still heal properly. That's why the incision is preferred to be placed ab-orally to the foreign body. As you can see in these images, the incision on the intestine must be caudal or distal or ab-orad to the foreign body. This is done to ensure that only healthy tissue will be the one sutured. After the incision is made, the foreign body, in this image is a rubber ducky, is milked out of the incision. However, in cases wherein the foreign body is lodged into the intestinal mucosa, you may extend this incision over the foreign body as much as you can to remove the material. After the removal, you have to assess the bowel viability again. The intestinal lumen is then lavaged copiously with warm sterile saline. Any spillage must be caught by your lap sponges surrounding the intestines. The incision is then closed with appositional full thickness simple interrupted suture pattern, or a simple continuous pattern would be good as well, as long as it is appositional, using a slowly absorbable monofilament suture. What are the examples of these sutures? That would be your polydioxanone, um, polyglecaprone. Some would actually use PGA or Vicryl, and that's okay, even if it's a multifilament one. Again, make sure you include the submucosal layer in your suture bites. The submucosal layer is the layer that contains the most collagen. That's why it is the toughest layer and of the intestine and of the stomach. That's why it is important that you include it in your suture bites. Also, the tunica mucosa tends to evert when you incise on it. That's why you cannot really suture the tunica mucosa just by its own. It tends to pop out of the lumen, so it's quite hard. You need to bury it again. That's why you need to suture through your submucosa. Most of the time, an enterotomy incision is closed longitudinally, as seen in the previous slide. However, if the intestinal lumen is small, longitudinal incisions may be closed transversely, as seen in this image. Observe the tightness of your suture. It must be tight enough, but not blanch the tissue and cause ischemia on the incisional margins. Leakage check is an important step after any intestinal closure. This ensures that your sutures will hold and no ingesta will spill once the abdomen is closed, and food and fluids will go through that segment again. With the intestine still occluded, as seen in this image right here, okay, get a 3 ml syringe with a warm sterile saline capped with a 25 gauge needle. You could use the orange one, and insert this through the intestinal wall. Carefully push the fluid into the intestinal lumen directed to the incision site and check if any fluid will leak out. Quite honestly, if you put so much pressure, even a good apposition on the wound would show leaking because you put so much pressure in it. So take care to simply simulate the pressure that the intestine undergoes when ingesta is flowing through it. If you don't see any leakage, then you're good to go. After passing a leakage check, omentalization can be done to facilitate intestinal wall healing. Omentalization is the placement of the omentum around organs or within cavities to improve vascularization and fluid drainage. The omentum houses an extensive supply of blood and lymphatic vessels, as seen in this image, and these lymphatic vessels contain inflammatory and immunogenic cells, which then stimulate healing and help prevent and resolve infection. The omentum is draped over the enterotomy incision and secured with simple interrupted sutures. A gauze sweep is done for the 4 abdominal quadrants to make sure no bandages are left inside, and you may proceed to doing an abdominal lavage with your warm sterile saline, especially in cases wherein it showed signs of peritonitis or hemorrhage. Make sure that you suction out all the fluid, or you wipe this with your laparotomy sponges. After that, once you're sure that there is no more hemorrhage, you have lavaged copiously, the abdomen is closed routinely with a 3-layer closure.